topic today.
Yep.
Giant cell arteritis. So let's go into our learning objectives. We would like you to understand the pathophysiology of the disease, understand the best tests for diagnosis, know how to treat successfully, and especially in your treatment, know what to do to avoid visual loss, which is the most devastating. Well, stroke is devastating.
Stroke,
too,
yeah.
But it is very devastating. So, all right.
So I guess we should start with pathophysiology,
Yeah.
which I like because it helped me think about treatment. So essentially you get activations of your dendritic cells and then attracts macrophages and you wind up with...
giant cells.
Giant cells. That's the name.
Amazing how that works.
Exactly.
Kind of like granulomas is how I like to think of them. Kind of the process. And it blocks off the blood vessels and the blood flow. So it's a disease of ischemia.
Yeah, and that's typically how they present. The classic person is in their 7th decade. And they say, what I think the article mentioned is that if they're under 50...
Yeah, 50 is a cutoff.
Really rethink your...
Think about your other rheumatologic diseases in people less than 50. Women more common than men.
Yep. 7th decade, headache, jaw claudication.
Tongue pain. I had a patient present with tongue pain.
Oh, really?
Yeah. It was very cool. I can't remember now how I got to the diagnosis, but we did a temporal artery biopsy on her, and that's what she had. And it got amazingly better.
Did she have the other symptoms, the constitutional symptoms?
No.
Nothing?
She didn't have fever, she didn't have weight loss, she just had tongue pain.
Oh, wow.
Yeah.
I'd have been like, ENT? No. Oral surgery? I don't know.
They would have never gotten it.
No, unfortunately not.
Scalp tenderness, and some myalgias can go with it too, so.
And then, I don't know if it's fair to ask the students, since we only have a student, the other big overlap. He's shaking his head, no way.
He's like, I'm not here.
Big overlap with PMR.
Yeah.
So.
And maybe even the same thing, we don't know.
Yep, exactly. I think the thing that I learned about too, so exam, I put this in there, is you can feel for nodularity. And the thing I didn't realize that I got from the article was they said to check pulses and make sure you listen to the heart. And the reason is when we started looking, aorta and so on, there's a good significant number of these people that have aortitis.
Yeah, and like we were talking, it's some of the same pathophys as Takayasu's. So again, pulse differences, all those things. The other thing I learned from the article, which is actually in JAMA of June of 2016, it's a really good article if you want to pull it, but is that you think of the classic of being able to feel a little beady temporal artery, hence the name, but that's only there 30% of the time. So don't trust it if it's negative. You're going to have to do biopsy instead, so.
Yeah, oh look, we got some fresh candidates. So diagnosis of giant cell arteritis, what do you guys want to start with?
Yeah, what's the best way to diagnose it?
Obviously a good history and a physical, so you felt for the beady temporal artery, scalp tenderness, lack of pulses.
Jaw claudication.
Jaw claudication.
So you've gone through the history and physical. What tests do you guys want to order?
ESR.
ESR, what's it going to look like?
Very high.
Very high. And that's true in 95% of patients. It's a great test. That's a rare, really value of that. So the thing I have to admit I've never done that was in the article is the imaging.
Yeah, I found that interesting.
Yeah.
So they mentioned ESR and CRP, and they said that about 86% of the time both are elevated. Sometimes you'll get one that's discordant.
Yeah.
Oh no. And so,
when that happens.
Yeah, so you have to go back to your clinical reasoning, but also, it turns out ultrasound, while not great, is actually pretty good.
You know what my theory is?
What's that?
Rheumatologists have ultrasounds and they're trying to find purposes for it.
Exactly.
But anyway,
it may be,
ultrasounds have the halo sign, which is supposed to be pretty good.
Yeah, the edema, the vessel edema.
Yeah.
It also made me think about what's the ultimate thing that we need to do to make the diagnosis.
Temporal artery biopsy.
Yeah.
And what do we need to know about that?
Pathological find.
Well, there's a couple things I think. What do you number one? What do you want to tell the surgeon? How much you want?
The surgeon wants to take at least a centimeter. Yeah. The surgeon wants to
tell
take
him
as
to
little
take
as possible.
6 centimeters.
Yeah.
Because it's a patchy disease. It's not continuous. So if you take a small piece, you can totally have normal findings, and you could have just missed the good findings. Sometimes you want to go back, if the first one's negative, go to the other side and biopsy.
Yeah.
But I think the point you're getting at is what about timing?
But it was the length. And
Okay.
the thing that made me think about that was too is maybe down the road somebody will look at it with ultrasound and say, gee whiz, before
Yeah.
surgery we did an ultrasound in these areas.
That's true.
Looked
That's a good way to
more
do it.
edematous. But
I like
I
that.
think, so we got to get them to surgery. So not only do we have to tell surgeons to take a good chunk, and also what about timing? Schedule them in June.
Soon.
Yeah, how soon is good enough?
Week or two.
Yeah. So
Yeah.
when do you want to start treatment? Do you like
Soon. Now.
the word for the day?
It's soon.
Very soon.
Right. And why is that?
Visual loss.
Yeah.
Because of visual loss. So you're going to start them even before you know they have it, right? But you do have a week and a half on high dose steroids, before the vessel starts reverting back to normal, that you can still use it as a diagnosis.
Yeah,
So
so
that's the key. Never wait worrying about whether you're affecting your diagnosis. Worry
Yeah.
more about the treatment.
And I think it's one of those things where I think the code word now is warm handoff. So if you have somebody you suspect, it's not good enough to put the consult in the computer.
Right.
This is one of those cases you pick up the phone and say, look, this is what I think, I'm going to start treatment, but we need to get this person
Yep.
in preferably within a week, but
Yep.
up to 15 days after you start.
And
treatment.
these are old patients, so how bad of a procedure is this? Do you have to pre-op them? Do you have to do anything for that?
I would say no. But
No,
Yeah.
it's an outpatient procedure. It's local anesthesia
Yeah, exactly.
generally. So it's not something you have to worry about in your elderly patients that are going to be higher risk surgically. So
And one thing I wondered about that I was going to ask you about, sorry, for this spot,
what if I'm wrong? You didn't prepare me.
This is the article sort of hinted, but it walked up to the line, but didn't cross it. It said, well, if you have somebody that's really classic, it's this old white woman and she has scalp tenderness and the beating thing, and you did an ultrasound and it looks good, just treat her.
No,
But I agree.
because
And, yeah.
steroids have a lot of
Yeah.
side effects too. So now I would treat somebody like that. I would treat whether the temporal artery biopsy came back negative or not, which is maybe their point.
Mhm.
But a positive test would give me much more assurance because I'm treating her for up to maybe 3 years with steroids,
I agree.
which is giving her osteoporosis and cataracts and diabetes, making her
Yeah.
diabetes worse. So
That was
my reasoning.
That was my reasoning, and
Okay.
my thought too is just that.
Phew, I'm glad I got that right. You're only supposed to put these guys on the
Oh,
spot.
jeez, I'm going the wrong way here.
Yeah, exactly.
So I think that we're in concurrence that I would
Yeah.
definitely push for the biopsy and
Yeah.
to have a good answer. And I think, like you said, even if you're really, really suspicious and you have some findings that aren't diagnostic but suspicious, maybe don't go for the other side. But I think if you feel otherwise, you still
Yeah.
go for the other side.
Right.
And then one thing that was helpful is reevaluate them after 5 days.
Yeah.
And if they're not making improvement, you need to consider something else.
It is miraculous
Yeah.
when they respond to it, and maybe more so in PMR
Mhm.
because they can't hardly get up out of bed in the morning. But it is just miraculous response to treatment. They're
Yeah.
dancing.
If they didn't respond to steroids, what are some of the things this could be? The article mentioned if you have synovitis, your diagnostic chances of being correct on giant cell arteritis is much lower. So it would be something that shows up as synovitis in the old person,
With a high sed rate.
the high sed rate.
What would that be?
Oh, it flares when the weather
Joints.
changes.
Yeah.
How about rheumatoid?
Yeah.
yeah.
Yeah. Lupus.
They also mentioned like cancer-related pain.
Yeah.
Myopathies, fibro, depression,
Yeah.
low-functioning thyroid. So those would be other things
Right.
to consider.
Which, I mean, kind of points to your workup, doing a CBC,
Mhm.
an ANA, anti-cyclic,
Yep.
CPK.
CP.
Those are all good. Yep.
And then, so if we're sure it's temporal arteritis, we start them on prednisone, how much? And is there anything else? I'm going to say hint, hint. One of the possible presentations is stroke that we would like to start them on.
So 1 mg per kg.
Yeah.
and aspirin.
Yeah.
Yeah,
A
so
baby
aspirin, because stroke is very high risk. And treating with steroids actually reduces your risk of stroke considerably.
Yeah, I think the benefit from aspirin, because the studies are so small, isn't. But I think the risk to benefit, they just said, well,
Right.
unless you think they're going to bleed,
Right.
you should probably put them on aspirin, which
Right.
seems. And a good
That's
chunk.
reasonable.
I bet you a good chunk of these folks are already on it.
Yeah,
Um,
that's probably true.
So high dose steroids, and when do you want to see them back?
A week.
1 to 2 weeks.
I would say a week to check and see. So you
See if
get
they're responding.
they're responding. You got your pathology back, and everything looks like it looks like it's giant cell arteritis. Okay, sounds good.
See you later.
See you later.
Have a nice life. What are you going to start doing with your treatment then?
DEXA, bisphosphonates.
Yeah, that's right.
haven't
Look
seen
for
rheumatology.
osteoporosis. Yep.
Yep.
Treat prophylactically.
I would also make sure that they're updated on their vaccines.
Yeah.
And
Their
make sure
immune system is affected.
if there's any reminders in there about vaccines that could potentially be live vaccines, I would make sure they don't get those.
Yeah.
And I think in selected case, what I put down, this is a Birch feeling, is that if they have other immunosuppression for some other reason, and you think they're going to be on high dose steroids, like you think
Yeah.
they've got a pretty smoking case, that I would consider PCJ prophylaxis.
I agree with that.
Um,
Especially for people you're not going to be able to taper.
Mhm.
Some people you can't, it's very difficult to taper off. And so,
They might be
those are people you
stuck
gotta- yes,
on that 60 a day
for a long time.
for a long time, and so and these are elderly people who are generally
Right.
frail. Yeah, so typically you want to see them back in 4 weeks, and then when sed rate and CRP are normalized, we start the taper, and there's a nice 10%
Yeah.
per week every 1 to 2 weeks.
But you got to follow them closely because they can flare
Mhm.
very easily. So sometimes, to me, going slower is the
Yep.
better route. Maybe every 2 weeks, and then keep checking every time. A lot of people can't get below the magic 20 milligrams a day too. You can get them down to that, and then they're going to keep flaring. And then it varies. I think most people need minimum. The article said is 8 months. My experience is at least a year. But
I
they
think
say
the
up to
average
3
was
years.
up to 24 months of treatment, so
Yeah.
it's a long time.
Yeah. So
And
hence the important about the osteoporosis treatment.
The big thing the patients mentioned was quality of life, was the side effect from steroids.
Yeah. Yeah. And you can use methotrexate in people that are tough to taper off. As kind of almost a little bit of a steroid-sparing agent. That seems to work. A lot of the newer biologics don't seem to have any effect on this disease, although I don't think there's been any big robust studies. They have tried some and it doesn't seem to work.
Yeah, the
well.
TNF alpha inhibitors flopped, but there's an IL-6 inhibitor that seemed
Yeah.
to work. But I think honestly, for my money, since it's been around so long,
Yeah.
I would do methotrexate. I personally wouldn't probably prescribe the methotrexate. I'd ask the rheumatologist to see him and say,
Yeah.
hey, you know what, I think we really need to consider a steroid-sparing agent. What do you think about methotrexate? It's
Right.
once a week, generally well tolerated.
Right.
We have a lot of experience with it. It's generic.
Yeah.
Versus like an IL-6 inhibitor, which is going to be expensive, not as well trialed.
More immunosuppression.
More immunosuppression. I think the visual loss.
Yeah. How often does it happen? What's your risk? If you have giant cell arteritis, what's your risk for visual loss? Take a guess. Everybody guesses that percentages. Come
Yeah.
on.
85%.
Oh, I
Oh,
like
my
that. But
goodness.
it's 20.
Yeah.
But I think the reason it feels like that much is because it is so devastating when it happens. So you are going to treat it like it's 85%. Because there's no good way to identify who is going to get visual loss and who isn't.
Yeah.
And sometimes, don't forget, patients present with visual loss. And so if you've got somebody presenting with visual loss, don't forget to try to go into the history of inflammatory symptoms, the jaw claudication and those kinds of things. We often kind of react and then miss it
Yeah. And
and create more visual loss.
if they present with visual loss, the treatment's different too.
Yeah,
You're treating like an MS exacerbation. You're giving
Yeah.
them a gram of slenimedrol.
yeah, that's true.
Yeah, so they're probably gonna go to the hospital
Right,
because they might go psychotic.
right.
They're steroid dose.
Their families will
And they'll be
thank you.
hyperglycemic, and it's got to be
Yes.
IV and everything else. So,
Yeah.
I
I'm
think
glad
that's
you
it.
remembered that. All right, so key points. Symptoms in the cranium for giant cell arteritis, such as jaw or tongue claudication, headaches, and visual loss, are the initial presentation. The ESR itself is elevated in more than 95%, but it is not as useful for following treatment. Treatment must be started soon as the disease is suspected and to avoid the visual loss like we talked about. And most people without the visual loss can get by with 60 milligrams a day with gradual taper. And methotrexate can be added for relapse or unable to taper. Simple.
Yeah. Questions, concerns, comments?
Is the visual loss reversible?
No, once it occurs, it's not reversible because it's like a stroke. It's an ischemic event. So, good question. Yeah. All right.
Okay.